Good afternoon, everyone. I'm Dr. John Shrigley, the Pathology Advisor at the Canadian Partnership Against Cancer and Chief of Lab Medicine and Genetics at Trillium Health Partners. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP Cancer Protocol Education Session on brain and CNS cancers. Before I introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. Firstly, the session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. Both the live and the recorded presentations are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note that CME certificates for each of the education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot technical issues as part of this call. If you are experiencing technical difficulties, please follow the support link included in the meeting package. We encourage you to submit questions at any time during the presentation using the chat feature within the Skype application. Chat instructions can be found in the session notice as well. During the question and answer portion of the presentation, a session moderator will pose the submitted questions on your behalf for as long as the time permits and in the order in which they appear. In the chat window, please include the following information: your institution's name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Julia Keith. Julia Keith has been a neuropathologist and study pathologist for the Brain Sciences Program and CNS Psych Group at the Odette Cancer Center and Sunnybrook Health Science Center for the last 9 years. Her academic interests include clinical pathological correlations in neurodegenerative disease and neuro-oncology, as well as neuropathology education. She is currently the Director of Continuing Professional Development and an executive member for the Canadian Association of Neuropathologists, and she was the Residency Program Director for Neuropathology at University of Toronto from 2011 to 2017. Her innovations in developing graduate and CPD educational programs in neuropathology have been formally recognized within the Graduate Education Award for Lab Medicine at the University of Toronto in 2017, acceptance to the prestigious New and Emerging Leaders Program at the University of Toronto, and promotion to Associate Professor at the University of Toronto on a platform of creative professional activity in both postgraduate and continuing professional education. Without any further ado, I would like to introduce Dr. Julia Keith to give today's talk on brain and CNS cancers. Julia?
Thank you. Thank you very much, Dr. Shrigley. I hope everyone can hear me. My name is Julia Keith. I'm a neuropathologist at Sunnybrook and the University of Toronto. And I want to start by thanking the Canadian Partnership Against Cancer and the Canadian Association of Pathologists, as well as Cancer Care Ontario for inviting me to speak today. This is a talk that's about classifying and especially about reporting tumors of the nervous system. And these are my objectives for today. So I hope to use case examples from my neuropathology practice at Sunnybrook to illustrate the content of the CAP brain cancer protocol. So this is a protocol that came out in 2014, and this protocol is embedded right within the reporting tools that I use every day, namely the CNS synoptic report issued by the CCO. The timing of my talk today is very interesting because since December 2014, we now have a new WHO classification for tumors of the CNS that came out in 2016. And this classification contains a lot of changes. So my second objective for the day is really, I'm going to try to show cases that demonstrate many of the changes within the new WHO. And I'm going to share with you a strategy that I've been using for reporting cases in which there's a difference between the 2014 CAP protocol and the 2016 WHO classification. For example, tumors that are newly defined entities in the 2016. I'm going to show you how I'm reporting those. Lastly, I have a few closing slides about some of the next steps that are coming down the pipeline in terms of brain tumor reporting. I'm going to admit this is an ambitious agenda. I think we have 90 minutes together in total, so my plan is to talk for about 60 minutes, and then I'm happy to try to answer questions and hear comments from everyone at the end. I have nothing to disclose. And I'd like to start here. So all of the College of American Pathologists cancer protocols can be found on their website. Their website is listed here. And here is the CNS protocols. The 2014 one, you can open it in a PDF version, and it looks like this. So the lead author was Dan Bratt, came out in December of 2014, and these are just 3 pages. It's actually quite a long document, but most of the protocol just consists of lists of various items that the CAP thinks should be included within a brain tumor surgical pathology report. At the end of the document, there are several pages of explanatory notes. But I will tell you that within this protocol, several pages are devoted to how to classify brain tumors. And all of that classification information is based on the 2007 WHO. So in my world, the CAP protocol is presented to me each day in this format. So this is what the CCO CNS tumor synoptic report looks like in our system. So at Sunnybrook, we use an Intuitive program. And when I'm writing my pathology reports in CoPath, I can open a link that opens Intuitive, launches Intuitive, and this is what I'm presented with. So all of the fields within the CAP protocol that need to be populated in my report are listed here along the left-hand side. And when I select one of these items, I'm given a drop-down menu of selections that I can make, and sometimes there are places where I can enter some free text as well. So I thought we could start with a very simple brain tumor case to show you how I populate the various fields in this synoptic report. So this is a 65-year-old woman presented to Sunnybrook with headaches, and she has this extraaxial mass on neuroimaging, looks very much like a meningioma on neuroimaging. There were beautiful examples of whorls on my intraoperative cytology preps. And then the permanent sections are quite an obvious-looking meningioma. There were several examples of atypical features noted in this tumor that I didn't photograph. So this is how I would populate the synoptic report in this case. So the first field to be dealt with relates to the surgical procedure. So my choices here are open biopsy, resection, or stereotactic biopsy. So I'm going to click resection, and then I hit next. It takes me down a line over here to the next one, which is specimen handling. So how did our pathology department handle this tissue? Well, in this case, there was an intraoperative path consult, so I did cytology preps. There was a frozen section, and the rest was submitted in formalin for permanent section, so I selected those 3 and hit next. Next comes the tumor dimension. So this information I acquire from the gross description that our pathology assistants have generated, and I have the option of just entering the greatest dimension, or I can also submit additional dimensions if I choose. Next is the laterality of the tumor. Is it on the right, left, midline, bilateral? Sometimes this information is submitted under the clinical information section of our requisitions that come from the OR. But to be honest, for each of my brain tumor cases, I'm going to open up the neuroradiology, have a look at the MRI myself, and have a read of the MRI report. I suspect that most of my neuropath colleagues would be doing the same thing for all of their brain tumor cases. So it's usually the neuroradiology images are where I get my information from the tumor site. So in this case, it was right. Here are my choices for the primary tumor site. In this case, it was dura, so I'll click dura. And this is an example where the CCO actually wants me to be more specific. So which region of dura was affected? In this case, it was the convexity dura, and then they want me to write lobe, which lobe of the brain was affected, so I write frontal and hit next. There were no additional sites involved by the tumor. This was a unifocal process, so I select none. And now we need to assign a histologic type. So these are our major categories of tumors affecting the nervous system according to the 2007 WHO. So I'm going to choose tumors of the meninges and click next. I told you this had atypical features, so this warranted an atypical meningioma, WHO grade 2 diagnosis. So that's my specific histologic type. It would like me to re-enter the WHO grade, so I put WHO grade 2. Now it's going to ask me for an assessment of the margins. So for almost all of my cases, I choose not applicable. Margin assessment is not a major component of neuropathology practice, with the exception of some of the malignant peripheral nerve sheath tumors, in which case I might state the margins being involved or not. The last item for me to populate is treatment effect. In this case, there was no treatment effect identified. So in this case, I signed this tumor out just on H&E. There weren't any additional studies that were requested or required. So at this point, I'm done populating my synoptic report, and I'm going to go up to the right-hand side and click Submit. And I'd like to show you an example of a signed-out surgical pathology report from Sunnybrook. I actually quite like the way we format our reports at Sunnybrook. I think they're well laid out. I think they're clear. I think they're easy to navigate. And all of the information that I just entered into the synoptic report automatically gets pasted into my final surge path report. It's highlighted in yellow here. The first item of my report is, of course, the most important. It's the diagnosis. I like to put my diagnostic line in capital letters and bold them so it's very easy for the reader to find. And I also wanted to say that synoptic reporting in my brain tumor practice really hasn't replaced writing microscopic descriptions. I still write at least a concise microscopic report for all of my brain tumor cases. Okay, so I'd like to switch gears now, switch from the topic of synoptic reporting to show you some of the new WHO classification for brain tumors. It came out in 2006. And there are several very good review articles that you can read, which are nice, concise summaries of the major changes. This is a good one by David Lewis, ACTA, 2016. And I'm going to borrow this table from David Lewis's review paper. I think it's an excellent summary of all of the changes in the new WHO. So this is David's table. The color coding is mine. So what I've done is I've highlighted the changes that I consider to be major overhauls to the classification system in blue. The green items represent entities or variants or patterns that have been added to the WHO classification. The orange items are entities, variants, and terms that have been deleted from the classification. And the things in yellow represent sort of a potpourri of additional changes that I'm going to refer to as tweaks to the WHO. So I'll show you a few more tumors of the meninges that demonstrate some of the tweaks to the WHO classification. This is a 77-year-old woman. She presented with word-finding difficulty, and she was found to have this extraaxial mass in her left middle cranial fossa. And our neuroradiologist noted that it had fairly irregular outlines, and they wondered if that was suggestive of brain invasion. But the truth is that neither the radiologists nor the neurosurgeons are particularly good at accurately predicting which meningiomas are going to have brain invasion. So instead, that task falls to the pathologist to make at the histologic level. And this is a fairly obvious example of a meningioma with invading the brain. The brain was wrapping right around this fragment of meningioma. So I'm showing this to you because one of the tweaks to the WHO is that brain invasion is now a standalone diagnostic criteria for an atypical WHO grade 2 meningioma. So the fact that we detected this focus of brain invasion warrants a diagnosis of a WHO grade 2 atypical meningioma. Otherwise, in the new WHO, there's been no change to the 15 meningioma subtypes, and molecular testing for meningiomas is not required for the diagnosis, the subtyping, or the grading. Here's another example of a dural-based tumor. This patient was younger at 33 years of age, and she had this lesion on imaging. The histology in this case shows a fairly densely cellular tumor, and you can see even at low power there really isn't a whirling architecture, so not really a meningothelial architecture to this tumor. On higher power, you can see a bit of collagen in the background. The nuclei tend to be quite oval and monomorphous, and there are very few mitotic figures. And this tumor was strongly and diffusely positive for STAT6, in a nuclear distribution. So this warrants a diagnosis of a hemangiopericytoma. The tweak to the WHO in this category is that solitary fibrous tumors and hemangiopericytomas of the CNS are now considered to be the histologic spectrum of a single tumor entity, and we're going to call that entity SFT/HPC. These are usually adults with calvarial dural-based lesions, and STAT6 immunopositivity, which can confirm the presence of a STAT6 fusion. It's highly recommended that this takes place by the WHO, but this is actually not a strictly molecularly defined entity in the new WHO classification. But I can tell you in my practice, I'm having a really hard time calling any dural-based tumor that's negative for STAT6 and HPC. The other tweak is we have a new three-tiered WHO grading scheme for these lesions. The tumor that I showed you was relatively cellular, but not very proliferative. It had very few mitoses, so that warrants a WHO grade 2 hemangiopericytoma diagnosis. Here's a second younger patient, also with a dural-based lesion. On histology, this was more densely cellular than the last case, had staghorn vessels. There were a number of mitotic figures, certainly more than 5 and 10 high-power fields. Can't see them very well on this low-powered image. It, too, had strong STAT6 positivity, so this warrants an anaplastic hemangiopericytoma WHO grade 3 designation. And here's the opposite end of the histologic spectrum. This is a more paucicellular tumor with a lot of collagen, ropey collagen, intervening in between these cells, which are quite oval and monomorphous. Also STAT6 positive. This is a solitary fibrous tumor, a WHO grade 1. In this case, it was from the spinal cord in a 40-year-old woman. Okay. So next, why don't we try to tackle some of these major overhaul items from the blue section of this table. And we'll start with really the most significant change, which is that we now employ an integrated diagnosis, which is a combined histologic molecular diagnosis, both for the diffuse or infiltrative gliomas as well as the medulloblastomas. So that is a paradigm shift for neuropathology. Historically, our classifications have been exclusively histologic. Now we have an integrated histologic molecular for 2 of our major tumor types. So this figure is also from David Lewis's review paper, and it shows how the diffuse or infiltrative gliomas have really been restructured. So all of the infiltrative gliomas, be they astrocytic or oligodendroglial, have been brought under one umbrella category, and that they are now classified both on their histologic features as well as their biomarker status for 2 important biomarkers, IDH and 1p19q. For example, glioblastomas are now divided into IDH mutant or IDH wild type variants. And I'll point out to you that this term of oligoastrocytoma has really been relegated to a very tiny minority of cases. This used to be a much more commonly employed diagnostic term, but now these are only cases where the histology truly is mixed, and it either has a dual genetic phenotype, which is really rare, or perhaps the genetic testing for IDH and 1p19q couldn't be done or is inconclusive. So that's really been relegated to the sidelines. So let's go through some examples of infiltrative gliomas, and I'd especially like to show you how I'm reporting these. So this is a 70-year-old woman with a several-day history of right-sided weakness and speech abnormalities, and she was found to have this intraaxial enhancing malignant-looking brain tumor that upon resection looked like this. So very densely cellular. You can see pseudopalisading necrosis along the side. On higher power, the background's fibrillary. The cells look astrocytic and atypical. It was quite proliferative, and there's examples of endothelial proliferation. So clearly a glioblastoma. This was IDH immunonegative, which means it's IDH wild type. So my integrated diagnosis is an IDH wild type glioblastoma, WHO grade 4. So I would populate the first part of the synoptic report in the same fashion that I showed you for the meningioma case, but now we have some special studies to report. So the immunohistochemical results I write here, and I've seen some pathologists just list the studies that were done. I actually type out the results. I can then just cut and paste them into my microscopic description to save a bit of time. But this is how I report some of the biomarker studies, including the IDH status, is in the immunohistochemistry section. Now it's time to assign a histologic subtype. So here's our list of major categories from 2007. I'm going to choose astrocytic tumors. And then I'm presented with the histologic subtypes of astrocytoma as per the 2007 WHO. So the new astrocytic entities are not on this list. And you'll notice this is an exclusively histologic classification. So there's no molecular information. It's certainly not integrated. My choice is going to be glioblastoma because that's as close as I can get with this list. But if I was to leave it like that in my synoptic report, it feels incomplete to me. It feels like my synoptic report is out of date. It's unsatisfying. So I've complained a bit around my department about that feeling, and this is what we've come up with at Sunnybrook to help me mitigate that feeling. So there's this additional heading in our CCO synoptic report called additional histologic types, and you can actually populate this subfield with whatever you want. So what we've done is we've created this. I just lost my presentation on my screen. One sec. Okay, there we go. Sorry, you guys, it's back. I hope you can still see it. Garan, if you can't, maybe you can let me know, but I'm just going to keep going. We've created this list that includes all of the newly defined entities, and it also contains all of the new integrated diagnoses that I might choose to select. So under glioma, you can see that I have two choices for an integrated diagnosis for glioblastoma, either an IDH mutated or an IDH wild type. So I'm going to choose IDH wild type. And here's what my final pathology report for this glioblastoma is going to look like. IDH wild type, glioblastoma, reads my diagnostic line. I was actually just reading the introductory pages of the WHO more carefully, and I have this inverted. So their official recommendation is to put the histology first. So it should say glioblastoma first, comma, IDH wild type afterwards. So I need to switch the order in my diagnostic line, and I'm going to do that. But I also want to show you how that modification that we've made with the additional list of histologic subtypes allows my integrated diagnosis that's on my diagnostic line to actually match the diagnosis that's listed in the synoptic report. And that makes me feel better. I feel like my report is more accurate. I feel like it's more complete. I feel like it's more up to date, having my synoptic diagnosis match my diagnostic line. The other reason I really like this modification is that Sunnybrook is a major teaching site for neuropathology. So most of the time, I have either neuropathology trainees or anatomic pathology trainees on service with me, and they're actually going to be generating these draft reports, populating the synoptic reports. And one of our major learning objectives for their rotation is for them to understand the 2016 WHO classification. So now the fact that we've sort of embedded that up-to-date classification in the reporting tools that they use every day, I find it's easier for them to wrap their minds around this classification system because they're actually using it. The last thing I want to say about glioblastoma reporting is I want to show you how I handle ancillary testing that's still pending at the time I sign out my surgical path report and the time I submit my synoptic report. So down here under the special studies category, there's a message from the CAP and CCO saying that pending biomarker studies should be listed in the comments section of this report. So that's what I do. I'll remind you this woman with a glioblastoma was 70, so we want to know her MGMT promoter methylation status. But at Sunnybrook, we don't have MGMT testing up and running in-house. So it takes 2 to 3 weeks to get that result, and I don't hold my reports in the meantime. So at the time of signing out my report, I just write in the comment section that MGMT testing is pending, and then when the result's available, I issue an addendum. I'll show you a few quick examples of other infiltrative gliomas. This is a 24-year-old man who presented with headache and aphasia, and he had, my goodness, it happened again. He has this large intraaxial brain tumor that's largely subcortical. It's not contrast enhancing. It was biopsied, and it showed an infiltrative astrocytic tumor of moderate cellularity. There's some nuclear atypia. There weren't any anaplastic features I could find. And these tumor cells were immunonegative. They had lost their nuclear ATRX positivity. So there's loss of ATRX. And they're immunopositive for IDH1. So my integrated diagnosis is a diffuse astrocytoma, WHO grade 2, IDH mutated. I populate the synoptic report the way I've shown you, and under this augmented list that we've added under histologic subtypes, I'm going to choose IDH mutated diffuse astro, WHO grade 2. Another example, 48-year-old man who presented with seizures. He too has an intraaxial brain tumor. It's a bit more superficially located. It's cortical and subcortical in its location, and it's not contrast enhancing. His biopsy showed an obvious oligodendroglial morphology, no anaplastic features. This tumor had maintained nuclear ATRX expression. It was immunopositive for IDH1, and when we did FISH testing, a 1p19q codeletion was detected. So this is the first example in which that I've shown you in which we had molecular results to include in my synoptic report. So I go down to molecular genetic studies, and I'm presented with this option only. It's a very limited list, and for some reason in the system, it'll let me choose either 1p deletion or 19q deletion, but it won't let me choose both, which is not very helpful. So I always just click other, and then I type in that 1p19q codeletion was detected by FISH. I'm going to choose oligodendroglial tumors from this list. From 2007 subtypes, I'm going to choose a WHO grade 2 oligo, and from my augmented list, I will find IDH mutated 1p19q codeleted oligodendroglioma. Okay, I want to point out this one other statement that exists in my CCO synoptic, and I actually have some questions for the CCO about how I should be handling this. So under special studies is this statement: for biomarker reporting for gliomas and embryonal tumors, the CAP CNS biomarker template should be used. So that's an entirely separate protocol. And if you go to the CAP website, where all of the cancer protocols are listed, you'll see in addition to the CNS protocol, there's a biomarker testing for the CNS protocol, also written by Dan Bratt. This is what it looks like. So it's a list that includes clinically relevant results for various biomarker testing, both for gliomas and embryonal tumors. And there's a section for methods used as well. And sure enough, CCO has a second CNS synoptic report that they've created with the identical content to that CAP biomarker protocol. This is what it looks like. So you enter the results of the various biomarker testing and you enter the methods, and it issues a second synoptic report. I'm showing this to you and I'm bringing it up with the CCO because I have never completed one of these. I've always been incorporating my CNS biomarkers into my primary CNS synoptic report. I haven't been issuing a second synoptic report. And I really wanted to put this question to the CCO. Should I be completing a second synoptic report on all my glioma and embryonal cases? And if so, why? What's the rationale for having us complete a second synoptic report? I would love to put that question to the CCO, and if there are reasons that I should be completing a second synoptic report, I'm all ears, and I'm willing to modify my practice. And I also want to say I've heard rumors around my department that perhaps ultimately, if provincial funding for some of this biomarker testing becomes available, will the provision of funding be linked to various institutions in a way that's somehow proportionate to the number of synoptic reports that are being issued? If so, that's a decent rationale for me to start using the second synoptic, but perhaps we can devote a little bit of time at the end of my talk to that question if Dr. Shrigley or anyone else from the CCO wants to speak to that. Okay, otherwise I'm going to move on. So back to this table. While we're on the topic of gliomas, I thought I would take the opportunity to show you some examples of some of the newly added entries to the WHO under the glioma category. So there are new glioma entities, there are new glioma variants, and new glioma patterns as well. This is the diffuse midline glioma, the H3K27M mutant. These are usually pontine and thalamic gliomas in children. This is an 18-year-old woman that I'm showing you with worsening bulbar symptoms. She really has the classic neuroimaging findings of one of these K27M mutant tumors, with a diffusely infiltrative glioma really expanding her pons, shown here on layer imaging. I don't have the histology from this case, but the histology of these lesions, they're infiltrative astrocytomas, and they can be of variable grade histologically. But the important point is that the presence of these K27M mutations confirms a worse outcome. And that's true for these tumors in the brainstem. It's also true for these tumors in the thalami. So I have exclusively an adult neuropathology practice. So my experience with these K27M mutant cases is going to be more limited than people who see more pediatric cases than I do. But we have had a few of them at Sunnybrook. Several of them have been young adults with intramedullary spinal cord lesions that looks very similar to this one. This is a 28-year-old woman who has this enhancing intramedullary spinal cord tumor. And here's her histology. So a very densely cellular tumor. And the background is really strikingly fibrillary. It's quite cellular. There's a lot of nuclear atypia. There were a number of mitoses, and there's endothelial proliferation. So this warrants WHO grade 4 histologic diagnosis. And I sent unstained slides down to sick kids where they did K27M immunostaining for me. And the presence of positive immunostaining is indicative of this mutation being present. So this was indeed a K27M mutant WHO grade 4 astrocytoma. So she was treated at Sunnybrook as per our usual spinal glioblastoma protocol, but this has just been a dreadfully aggressive disease course, which has been our experience with the few young adult cases that we've had. It's just a devastating disease. Within 4 months, despite her treatment, she has disseminated leptomeningeal disease up and down her spinal cord, and also intracranially. Here it is wrapping around her pons, wrapping around her medulla. So I wanted to mention that this K27M immunohistochemical testing is available at Sick Kids. I believe they're quite happy to stain these cases for us and review them for an opinion if desired. I am not sure whether any of the other pediatric centers in Canada have validated this test. I don't know, Chris Dunham, Odin, BC, if you have it up and going. I wonder maybe Saint Justine in Montreal. I'm not sure. But in terms of indications for testing, I can tell you what I'm doing. So all of the midline IDH wild-type gliomas in young adults, so anyone less than about 40 years, I've been sending for testing, and we've had a few positive ones. So that includes the spinal cord lesions I've shown you, any brainstem glioma, cerebellum, thalamus. I have one on my desk right now of a young adult with a pineal region astrocytoma, which is K27M mutant. So these are the cases that I'm sending down to Sick Kids for testing. So the next new glioma entity is the diffuse leptomeningeal glioneuronal tumor. This is mostly a pediatric tumor. It can be seen in young adults. I have no personal experience with this entity, so I pulled images off the internet. They have extensive leptomeningeal growth, especially at the base of the brain and wrapping around the spinal cord. They may or may not have an intraparenchymal component. And when I read the few papers in the literature about this entity, this is a good one from ACTA 2012. They are reporting on 36 cases with a median age of 5 years. And the histology really is a diffuse leptomeningeal growth pattern, but the cells look like this. They're very oligodendroglial, and they can either exist in featureless sheets or sometimes in these nodules. And it's this oligodendroglial-like appearance that led to this tumor previously being called disseminated oligodendroglial-like leptomeningeal tumor of childhood. This paper also points out the abundance of desmoplasia in these tumors. They're mostly of low-grade histology, although no WHO grade has officially been assigned this category. They're IDH wild type. They often have loss of 1P, and then this follow-up paper from the same group described the vast majority of cases having a BRAF fusion. Okay, so pleomorphic Xanthoastrocytoma is not a new diagnosis for neuropathologists. In the 2007 WHO, PXAs are a WHO grade 2 entity, but for a while we've had the option to use a diagnosis of PXA with anaplastic features to which a WHO grade wouldn't be assigned. So the new change in the 2016 WHO is that we now have enough information to say that an anaplastic PXA is a WHO grade 3 designation. And this is the major paper from Brain Pathology, where they reported and followed 74 patients with PXA. And what they described is that there are certain histologic features, namely more than 5 mitoses in 10 high power fields, or the presence of necrosis, that actually significantly affected outcome. So we thought that was enough information to warrant this now being a WHO grade 3 diagnosis. BRAF V600E fusions often present. There is a new variant for glioblastoma, the epithelioid glioblastoma. So that now joins the list of giant cell glioblastoma and gliosarcoma as being the recognized glioblastoma variants in the WHO 2016. Epithelioid glioblastoma mostly occurs in children and young adults. It can be an especially aggressive clinical variant. This is a case actually from my residency in London. So this epithelioid glioblastoma had areas of necrosis, and it's a nice example of the typical histology of this case, of this entity. So the tumor cells have very distinct cell membranes. They have wildly pleomorphic nuclei, copious amounts of eosinophilic cytoplasm, really a very epithelioid look. They are IDH wild type, and about half of them have a BRAF V600E mutation. I think the major histologic differential diagnosis here would be an anaplastic PXA, which I just showed you. I think that can sometimes be a tricky distinction to make between the two. I think anaplastic PXAs look more xanthomatous than these, and certainly if you had a history of a lower grade PXA, that would push you towards an anaplastic PXA designation. There's also a new pattern of glioblastomas called the glioblastoma with a primitive neuronal component pattern. So in these tumors, in some areas, there's a classic infiltrative high-grade astrocytoma, but you also have these areas that are sharply defined nodules that are comprised of they're very densely cellular, and the cells look very embryonal, and they label with some embryonal markers, and they can be synaptophized and positive and more proliferative than the rest of the tumor. Is this a clinically relevant pattern? They may be more prone to CSF spread. We've had a number of these at Sunnybrook, and we're treating them just with our usual glioblastoma protocol. And there are no specific neuroimaging features that have really been defined for this pattern, but I'll tell you a number of our cases at Sunnybrook have this large cystic component on their neuroimaging, which is interesting. There is a new genetically defined ependymoma entity, the RELA fusion positive ependymoma. Again, I'm an adult neuropathologist. I have minimal personal experience with these. I've been talking to Cynthia a bit in preparation for this talk, and she's told me a bit about their sick kids' experience with the RELA fusion positive ependymomas. So 70% of childhood supratentorial ependymomas and a few adult supratentorial ependymomas have a RELA fusion. This is a fusion that's not present in the posterior fossa or spinal cord ependymomas. At sick kids, they're using fish looking for the presence of these RELA fusions. They are doing fish chest testing for RELA on all of their supratentorial ependymomas. I intend to send any adult supratentorial ependymomas that come my way to sick kids for RELA fusion testing. There's also some papers describing some useful immunohistochemical tools to identify these RELA-fused ependymomas, L1-CAM and P65. They're not using these at sick kids. I don't know if other neuropathology practices are using these, and if so, are they finding them helpful? I'd love to hear about that. Histologically, they can be either a WHO grade 2 or grade 3, but in the sick kids experience, they tend to be more anaplastic. They can actually have a bit of a peanut look to them. There's a new tumor entity called a multinodular and vacuolated pattern of ganglion cell tumor. This case I'm showing is thought to have this diagnosis, although it hasn't been histologically confirmed. This is a 37-year-old woman who this lesion was just incidentally detected. She was completely asymptomatic. She didn't have seizures, as many of these patients do, so she subsequently hasn't undergone a biopsy or a resection. But this does show the relatively classic neuroimaging findings of this newly described entity. So see, look how nodular this tumor is, and it's very subcortical in its location. When I have a look at the pathology of this entity that's been described in the literature, so here's again neuroimaging that looks a lot like our case. But the pathology of this entity, it's comprised of these very well circumscribed nodules in the subcortical white matter. They can coalesce, and these nodules are hypomyelinated, which makes them look very gray on gross examination. They almost look like a demyelinating plaque. And then if you look more closely within these nodules, the background neuropil is very vacuolated, and there's a two-cell type. So the dominant cell is this one, which is neuronal in nature, and the cytoplasm is extremely vacuolated. So it's sort of, this is a double vacuolating phenomenon. The neuropil is vacuolated, and these neuronal cells are also vacuolated. And the second cell type you might encounter are these, which are oligodendroglial-like cells that are often clustered. This is a lesion which is IDH wild type, and it's BRAF V600E negative. I just wanted to show you how all of these new tumor entities in the 2016 have made it onto my modified synoptic report list, so that when I encounter them, I can use my synoptic report to accurately and in an up-to-date fashion report them. This is my last glioma case to show you, and it's the only autopsy case that I managed to include. This was a 65-year-old man who actually had a very rapid neurological disease presentation. He was admitted to hospital with a 2-day history of confusion, and then he got much worse very quickly. He started seizing, he went into status epilepticus, and he died. And on imaging, they saw this asymmetrical cerebral edema that was much worse on the left. They thought he likely had an encephalitis, although his infectious workup was negative at the point where he died. And this is the gross photo from my neuropath autopsy examination. And you can see the asymmetrical cerebral edema like they did on imaging. His whole left hemisphere is much larger than his right, and there's a little bit of midline shift and mass effect as well. And histologically, throughout his entire left hemisphere, this is what I found. So the whole left side of his brain was overrun with these, which are elongated, rather atypical looking astrocytic cells. These are GFAP immunopositive with some coarse cytoplasmic processes. They label with P53, and there were a number of mitotic figures. The Ki67 proliferative index was rather high, but these cells were immunonegative for IDH. So historically, neuropathologists would have used the term gliomatosis cerebri in this context. But in the WHO 2016, this language has been removed. So instead, we're just going to use the same principles that we used for other diffuse gliomas to assign an integrated diagnosis. So histologically, this met WHO grade 3 anaplastic criteria because there are a number of mitotic figures, and it's IDH wild type. So this is an anaplastic astro, IDH wild type. Gliomatosis cerebri is no more. Okay, that is all I wanted to say about gliomas. I'm just checking the time. It's 1:45, so I'm going to keep going and talk a little bit about medulloblastomas and embryonal tumors, and I think I'm on track to be done at about 2 o'clock or maybe 5 minutes after 2, and then we can have questions. So medulloblastomas and embryonal tumors are the other major category that has really undergone an overhaul. So I mentioned before that medullos are also now to be reported with an integrated diagnosis. So how does one come up with an integrated diagnosis for medulloblastoma? So we start with histology, and there are 4 different histologic patterns in medulloblastoma. This is an example of a classic histology, which is really a typical small blue round cell tumor. It's lacking desmoplasia, and it's lacking marked cytologic atypia. The second histologic pattern is the desmoplastic nodular medulloblastoma, and the WHO emphasizes the importance of doing reticulin staining in this context because nodular growth alone can be seen in the other histologic patterns. Nodular growth without desmoplasia doesn't qualify. You need to have both, and the desmoplasia can really be subtle on H&E. So it's very important to do the reticulin staining to highlight the desmoplasia between the nodules. I should have added one figure ago that, again, adult neuropathologist, I have minimal exposure to medulloblastomas. So Cynthia at Sick Kids has very generously helped me to populate this section of my talk with histologic figures that she provided, and I also chatted with her quite a bit in the last week or two to make sure that I had something intelligent to say about how to handle these embryonal tumors. Thank you, Cynthia. Okay, classic I've shown you, desmoplastic nodular. The third histologic pattern is medulloblastoma with extensive nodularity and advanced neuronal differentiation. So compared to the desmoplastic nodular variant, these nodules are larger and they have more abundant neuropil, and the reticulin-rich zones in between them are thinner. So here's another change to the WHO. The large cell variant and the anaplastic variant used to be separate entities, but now we've recognized that the large cell and the anaplastic morphologies usually coexist in a single medulloblastoma. So they've been combined into a single pattern, and this pattern really has to be present in the majority of the tumor to qualify. So this figure from Cynthia is showing the large cell histology, where the cells are actually relatively uniform and they're large and they have large prominent nucleoli. So the histologic pattern of medulloblastomas remains clinically very important. It predicts outcome, for one thing. So the desmoplastic nodular medulloblastomas do the best. The large cell anaplastics do the worst, and the classics are in between. But the second part of the integrated diagnosis is the molecular subgroup. There are 4 molecular subgroups of medulloblastoma: the Wnt-activated group, the sonic hedgehog activated group, and the subgroup 3 and the subgroup 4. So each of these molecular subgroups have their associated demographics, and they can also have some distinct neuroimaging features. So the Wnt-activated tumors are shown here on the left. They have a rhombic lip origin with extensions into the lateral recesses of the brainstem. The sonic hedgehog tumors are more laterally located in the cerebellar hemisphere. Both the group 3 and the subgroup 4 tumors are within the fourth ventricle, but the group 4 tumors are relatively poorly enhancing. So just like the histology was a predictor of outcomes, so too is the molecular subgroup, and this is from a meta-analysis of 7 different studies over 550 medulloblastomas. And what they found is that molecular subgrouping predicts outcomes when you lump all of the medulloblastoma patients together, but it's also true when you stratify them out based on age. So it's an important determinant of outcome. The other important predictor of outcome is the presence or absence of a p53 mutation. And again, that's true for all medulloblastomas if you lump them together. And it's especially true in the sonic hedgehog activated group. So this is the table I took directly from the new WHO. And the reason why medulloblastomas, I find them hard to wrap my mind around, and it's because if only the histology were an accurate predictor of what the molecular subgroup was going to be. But sadly, that's not the case. The histology can combine with the molecular subgroup in a variety of ways, not in every possible way, but in a variety of ways. And this table from the WHO shows all the different ways in which the histology can combine with the molecular subgroups. So this is a long list. And I don't see a lot of medullos. To be honest, I have to look this list up every time I'm presented with one of these cases. But there are a few strong relationships that take place, and there's a few that I've committed to memory over time. So the first is that the classic histology and the large cell anaplastic histology can occur in any of the molecular subgroups. The second thing to say is that almost all of the Wnt-activated medullos have a classic morphology, a classic histology, and these tend to be very well-behaving tumors. These patients have good outcomes with standard therapy, and Cynthia was just telling me that there are a number of clinical trials underway to see whether or not we can safely de-escalate therapy for these Wnt-activated classic medullos, and will they have as good of outcome as they do with standard therapy. The third thing I wanted to point out is that the desmoplastic nodular histology and the extensive nodularity only occur in the sonic hedgehog activated subgroup, but the sonic hedgehog activated subgroup is in itself quite heterogeneous. For example, if a medulloblastoma is sonic hedgehog activated with a p53 mutation, and a large cell anaplastic histology, these are actually very aggressive tumors. The patients don't do very well. On the other hand, a sonic hedgehog activated medullo, p53 wild type, and either a desmoplastic nodular histology or extensive nodularity, those tumors do quite well, especially when they occur in infancy. So it's a heterogeneous group. You won't be surprised to learn that this long list that we've added to our synoptic report includes all of the options for an integrated diagnosis for medulloblastoma. So I have the option of including that in my synoptic reporting. My last point about medulloblastomas is that there are these two additional morphologies that can occur, and they occur in the setting of either a classic histology or a large cell anaplastic histology. And those are medulloblastoma with melanotic differentiation and medulloblastoma with myogenic differentiation. So here's another case from my residency in London. This was mostly a classic histology medulloblastoma with these areas of very recognizable skeletal muscle differentiation, and they were immunopositive for desmin. So at the time, we called this a medullomyoblastoma because in 2007 WHO, that was a distinct variant. So the language has changed a bit. They're no longer considered distinct variants. They are rather morphologies that occur within one of these two histologies, and this is the way to report them, medulloblastoma with myogenic differentiation. So we have this integrated diagnosis and all of this molecular information. What are the recommendations on how should we work up a medulloblastoma, and how should we arrive at this integrated diagnosis? The WHO doesn't actually give us specific guidelines for how to accomplish this integrated diagnosis. There have been previous consensus criteria that advocated for using two different testing techniques to define a molecular subgroup, and that is what they're doing at SickKids. So at SickKids, they're doing immunohistochemistry for beta-catenin, filamin, and p53, plus they're doing reticulin to help identify the histologic subtype. So beta-catenins should identify the Wnt-activated ones, filamin should identify the sonic hedgehog. I don't think there is immunohistochemistry that can help you identify subgroup 3 or subgroup 4, but their immuno is one of the platforms they're using to define the molecular group. And then they're doing nanostring as well. I'm not sure if any of the other centers across the country have nanostring up and running for medulloblastomas. I talked to Stephen Yip at UBC. He's, I think, thinking about getting something going. So whether Sick Kids right now is the only referral site or one of the only referral sites, I'm not sure. In my practice, as I mentioned, I don't see medullos very often. I do occasionally see adult onset cases. I've also had some adult recurrences from patients who were diagnosed with medulloblastomas in childhood, and I've been sending those cases. So if their original pediatric diagnosis was not molecularly subgrouped, I've been sending them to Sick Kids. And also, if it's an adult onset case, I've been sending those as well. My read of the WHO is that if a neuropathologist has the ability to apply these integrated diagnoses for medullos, they should do so. And I certainly feel like I have the ability to do that. Okay, the remainder of the embryonal category has also significantly been revised. So this is the old list for embryonal tumors, and you'll see that the peanut term, primitive neuroectodermal tumor, looms large on this list. In the WHO 2016, there no longer exists the entity of a peanut, and there are several new types of embryonal tumors. Here's one, the embryonal tumor with multilayered rosettes, or ETMR, C19-MYC altered. So this is a molecularly defined entity. To qualify for this diagnosis, a tumor has to have amplification or fusions in the C19-MYC. This is mostly a tumor that affects young children. It's mostly hemispheric, but it can occur in the brainstem or cerebellum, and they tend to be very aggressive. Again, I have no personal experience with this entity, so these figures are coming from Cynthia, thank you. There are 3 different histologic patterns of an ETMR C19-MYC altered. This image is showing the ETMR histologic pattern. So all 3 of the patterns feature rosettes, but the ETMR pattern is biphasic in nature, and it has these paucicellular areas with a lot of neuropil, plus these clusters of embryonal cells with the multilayered rosettes. I borrowed this figure from this 2014 ACTA article that's reporting on 97 cases of ETMR, and I think this figure nicely shows the 3 different histologies. So here's the ETMR histology I just showed you. The second histology is an Ependymoma histology. These are not biphasic tumors. They lack the neuropil areas, and they're just exclusively comprised of clusters or sheets of embryonal cells with these multi-layered rosettes. Lastly is the Medulloblastoma pattern. So these feature these tubular structures that look a lot like the primitive neural tube, and these tubular structures are surrounded by this external limiting membrane. I think sometimes distinguishing these 2 entities can be difficult, but all 3 of these patterns have amplification at C19, and therefore they qualify for this diagnosis. This paper is also talking about an immunohistochemical antibody, Lin28A, which I have no experience with, that apparently can identify all 3 of these entities. Although it sounds like it's not a terribly specific antibody, it also labels some gliomas, ATRTs, and other things. The C19 MYC molecular study is being done at Sick Kids. I think most centers are referring their cases to Sick Kids for testing. I think they're doing FISH at Sick Kids for this. The Medulloblastoma histology can occur with or without a C19-MYC amplification. So in the presence of an amplification, then the diagnosis is an ETMR, C19-MYC amplified. But if a C19-MYC amplification is not present, then in the WHO, the diagnosis is a Medulloblastoma. WHO grade 4. All of these embryonal tumors are WHO grade 4. What about the Ependymoma histology or the ETMR histology? So if either of these have the C19-MYC amplification, then they're an ETMR, C19-MYC amplified. But if they don't, this is the language recommended by the new WHO. Embryonal tumor with multilayered rosettes, not otherwise specified. So an atypical teratoid rhabdoid tumor is not a new entity for neuropathologists. The change in the new WHO is that it's now molecularly defined entity. So you have to have deletion and mutation or mutation either in INI1 or BRG1 to qualify for this diagnosis. And there's immunohistochemistry available to detect for these. The endothelial cells here are positive. The tumor cells are immunonegative, so the mutation is present. If you have something that you think is an ATRT, and the INI1 and the BRG1 are either retained or you're not able to examine them, then the WHO diagnosis is CNS embryonal tumor with rhabdoid features. All of the new embryonal tumors are listed in my modified synoptic. Here's a practical list of entities to consider when you're dealt a brain tumor that has a PNET morphology. So obviously ruling out an ATRT is important. There's a number of gliomas that can have a PNET morphology. I mentioned the RELA fusion ones. I mentioned the glioblastoma with primitive neuronal components. But here's a Sunnybrook case illustrating something else to consider. This is a 22-year-old man who came to Sunnybrook for recurrence of this frontal brain tumor. And I had Andrew Gow, who's a neuropathology resident, on service with me, and he actually recognized this entity. On histology, this was a very widely infiltrative brain tumor. It was these secondary structures of shear, but they were really exuberant, layers upon layers of cells surrounding the neurons, surrounding the vessels. And the cells themselves had an embryonal look. And this is our routine glioma panel. Showed they were positive for P53, ATRX loss, and IDH was wild type. So Andrew recognized that combination of morphology and immunophenotype and suggested that we send it to sick kids to look for one of the histone mutations that can happen in gliomas. And indeed, this tumor was immunopositive for the histone G34R. They're doing this immunotesting at sick kids. Cynthia has cautioned me that it can be patchy and difficult to interpret. Sometimes they back it up with PCR. Okay, I'm actually going to skip my few slides on the peripheral nervous system tumors and come to my concluding slides about next steps for brain tumor reporting. The obvious next step is to modify the CAP protocol so that it now includes the 2016 WHO classification. I'm not involved in this process at all, but I've been told that the new CAP protocol may be available in August 2018, so I look forward to hearing what the CCO is going to do with that and how our synoptic reports are going to change. And I wanted to bring your attention to two other items before I close and take questions. The first is this phenomenon. So the International Collaboration on Cancer Reporting, or the ICCR, is a large international group of experts that convene and come up with data sets, making recommendations for what the content of surgical pathology reports for different site groups should be. And they are working on one for the CNS. And they're actually in the open consultation stage. So a draft data set for this ICCR CNS template is available. And we're actually being asked to have a look at this and provide feedback. So you would have gotten an email from the CAP requesting some feedback from you as a neuropathologist on the content of this data set. You're also going to get another email from me, maybe tomorrow, in my capacity with the Canadian Association of Neuropathologists, because we're also going to solicit feedback on this ICCR data set. And then we've been asked to collate feedback from our membership and provide that to the International Society of Neuropathologists as well as the CAP. So we'll do that, and please have a look at these and respond to my email. The last thing I want to say is if you're a member of the Canadian Association of Neuropathologists, you will have heard about this survey already and probably feel a bit pestered by me about this survey already. But I think this is a very important initiative. So Stephen Yip and Adrienne Levine at UBC are working on a Canada-wide survey about neuropath molecular diagnostics. What diagnostic tools are available? How are people using them? What are the referral patterns? There's a real pressing need for us to have a better understanding of which centers have what testing capabilities. And Stephen kindly provided me with an update about his survey. So in a nutshell, if you haven't completed this survey, I'm going to really strongly encourage you to do so. But to date, they've gotten 27 respondents, and these are the institutions from which they've received responses in Canada and the US. So if you're listening to this talk and you're a neuropathologist at a site that's not on this list, please complete Stephen's survey. It's actually going to be very helpful to our association and I think to us in our individual practices. Stephen has some preliminary results about which techniques are most frequently available in-house And so far, none of the clinical tests are being performed outside of clinically accredited labs. He also has some preliminary data about what tests people are most commonly sending out, and that the majority of them are sending cases within the same city or province. Here is the link to the survey. Again, this is a reminder to complete the survey. Will be in that CANP email that you get from me in the next day or two, so please take the time to complete it. With that, I just want to conclude. Especially, I want to thank my clinical collaborators, especially the members of the CNS Psych Group at the Odette Cancer Center, for being such a pleasure to work with every day, but also for helping me put together the case examples. A huge thank you again to Cynthia for helping me generate some meaningful pediatric content to this talk. And Tanya Jordan is our Labs Information System Analyst at Sunnybrook, and she's the one who patiently helped me modify the synoptic report so it was in a format that I thought was more up-to-date and more usable. And with that, I'm going to conclude, and we have a bit of time left for questions and comments. Thank you very much, everyone, for listening.
If anyone has any questions, please type them into the chat window at the side of your screen, and then we can go through those questions one by one.
While we're waiting for questions, we did get 2 comments thanking Dr. Keith for an excellent presentation.
Thank you. Thank you for the positive comments. Thanks for sharing them. I can also share that I got an email from Jeff Joseph in Calgary telling me that indeed in Calgary they do have H3K27M immunostaining, so it is available outside of Toronto.
We have a question from Peter Gould. What do you do for tumors which do not fit into the official WHO format? For example, H3G34.
Yep, that's a good question. So what I did with the H3G34 is I signed it out as a recurrent IDH wild-type glioblastoma. And then in the synoptic report, I added the H3G34 immunostaining results to the list of immunohistochemistry, and I added a comment both within the synoptic and in my report just saying that this immunohistochemical result confirmed the presence of this mutation. I think that case is a nice example, though, of the clinical impact of getting rid of that peanut terminology. Like, I think historically, a lot of these cases that are actually gliomas, we may have called them a peanut, and that's a clinically relevant distinction, right? The treatment plans are different for embryonal tumors in peanuts than they are for gliomas. So I think as we tease things, we pull things out of this old peanut category, changing their designation sometimes is very clinically relevant. If we're waiting, if we're giving people a few more minutes to type in their questions, is Dr. Shrigley or anyone from the CCO able to speak to my question about the value of doing the second biomarker synoptic report?
I can make a few comments. Can you hear me? Can you hear me, Julia?
I can. Yeah, thanks. That would be great.
I'd like to make 3 comments. First of all, I'd like to thank you for the ICCR plug. And I encourage people to go on our website, iccr-cancer.org, to check out some of our data sets that are on that site. The CNS one is out for public consultation, as Julia has noted. It's a layered data set for structured reporting. The one layer is histological, the second layer is molecular, and the third layer is integrated. I think it's a very nice way of doing these sort of things. And our data set chair for that particular data set was David Lewis, and of course it's based on the WHO 2016. So I encourage people to comment on it while it's out for public consultation. Secondly, I'd like to comment on the WHO 5 cycle. The new series of WHO Blue Books have started as of February 2018. The CNS one is actually slated to be written in 2020 for release in 2021. So we're actually going to reduce the cycle for the Blue Books from 10 years to 5 years. So hopefully that CNS one will be updated by 2021, which is great because of all the changes in molecular pathology, et cetera, that have occurred over the recent years. Thirdly, regarding CCO, Julia, I stepped down as the head of the CCO lab medicine program back in 2013, so I think we're going to have to direct our questions to Aaron Paulette and Jennifer Hart. Aaron, of course, is the pathology lead, and Jennifer Hart is the manager for that program, so I'm not sure if one of them is on the line.
Hi, sorry, it's Josh Mazurek. I'm the Pathology Standards Advisor at Cancer Care. Dr. Paulette actually had another meeting to attend to at 2 o'clock. So some of the confusion is related to the current synoptic ECCs, has to do with the fact that the CNS ECC has not been updated. We are expect an update in the summer, which will resolve some of the issues. The biomarker checklists has been mandated and is as not all centers have the capacity to do the biomarkers in-house. Using the checklist allows the sites doing the tests to report the results in a standard way. We would not expect biomarkers to be entered in 2 locations. The biomarker checklist is preferred, but at this point either checklist would be acceptable. And we're happy to follow up on this at a later time, especially with an Ontario hospital working group call or something.
Can I ask another question of the CCO? So I'm glad to hear that there's going to be an update to the CNS synoptic at the CCO level this summer. Do you have neuropathologists who are a part of that process?
The neuropathologists themselves are the ones that would be working on the cancer protocols at the College of American Pathologists.
Okay.
Yeah. We just adopt the ECCs and the cancer protocols.
Okay. I don't clearly understand what the relationship is between the ICCR data sets and the College of American Pathologists protocol. Like, will the new CAP protocol be informed by the content of the ICCR data set once it's complete?
I can comment on that, Julia. The ICCR was created about 6 years ago. And the founding members are the College of American Pathologists, the Royal College of Pathologists of the UK and Australasia, the European Society of Pathologists, the Canadian Association of Pathologists in association with CPAC, and more recently the ASCP and the Royal College of Physicians of Ireland. So they're the sponsoring members of this organization. We have a very structured approach to doing data sets with a very solid evidence framework. But what's happening now is that as the ICCR data sets are done, they're actually informing some of the national data sets like CAP and RC-PATH, so that I think eventually over time they're going to converge, certainly with respect to the elements that would be considered mandatory. The College of American Pathologists is represented on the ICCR, and it's sort of a to and fro right now, but I think eventually over the next decade or so, as this is done in sync with the WHO Blue Books, we're going to see a harmonization of data set elements, especially the mandatory ones.
Okay, that's helpful. Thank you. I know I'm going to go online and have a good look at those ICCR data sets myself. It seems like an important initiative, and really they are soliciting a lot of input from neuropathologists. So when you guys get an email from me or from the CAP asking for your opinion about these data sets, please take a few minutes, because I think they are genuinely looking for feedback.
Well, I guess if there's no further questions, I'll go ahead with the closing remarks. On behalf of the Canadian Partnership Against Cancer, CCO, and the Canadian Association of Pathology, I'd like to thank Dr. Julia Keith for a very great presentation today. As a reminder, both the live and recorded presentations are eligible for CME credits. In order to request your certificate of participation, please provide your name and email address at the link included in the session notice. Here you will also find an optional session evaluation form, which we encourage you to complete. The information collected through this process allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. Please see the notice for more information. This is the fourth and the final session of the 2018 CAP Cancer Protocol presentation. And we would like to thank everyone for their participation. And we also would like to solicit information and ideas for future events as well for 2019. Certainly, if people can give us the topics that they'd be interested in, that would be most appreciated. Thank you very much.
Thank you, everyone.
Okay, thank you. Thanks for everyone for listening.